So should we start now? Okay. Thank you very much. And thank you very much, dear friends, for joining us again in yet another session of BRENDOS WUP. Those who have joined recently, BRENDOS uh, is an online forum, a learning platform where we meet on a monthly basis and we discuss about breast and endocrine related cases on an alternate basis. So like in even months we discuss about breast cases, in odd months we discuss about endocrine cases. And this program is really very unique in the sense we just cannot don't discuss about any problem, we discuss about a case in a holistic view. So in this forum, the microbiologists, pathologists, radiologists, nuclear medicine physicians, or any other specialty who have ever been there in the involved in the management of any particular patient, we come together on this platform, we describe the images, the real images, be it pathology, radiology, surgical images, uh, and we discuss about those, we show those images so that we have a deep impact, a better understanding of that particular problem. And along with that, we discuss about the follow-up of the treatment so that the pathologists, radiologists, those who usually don't know about what happened with their report, they can understand also what happens with their report, how their report impacts, how their report impacts the management of the patient. And so that ultimate aim is to improve ourselves. Okay, so friends, here today also we have again joined to discuss about some very interesting problem. And to start this session, I request our moderator, Dr. Swati, who is a very renowned microbiologist, a great academician. She is passed out from LLRM Medical College, and presently she is working as an associate professor in the NCR Medical College, Meerut. To start the proceeding, I am very thankful to ma'am. She has taken out time from her busy schedule, and not only that, I come and help us in this session. Dr. Parul Pudi. Dr. Ritu ma'am is with the directors in a directors meeting, so she will join late. So she said we can start the meeting. Dr. Parul is with us. Yeah. Thank you very much, ma'am. So now I'm sharing my screen for everyone to see. इसको full screen. इसको नीचे से screen. Okay. इसी को ही screen कर देते हैं. ठीक है. Fine. So, is this screen visible to everyone? Hello. आवाज आ रही? आवाज? Okay, but I'm not able to hear anyone. Okay, fine. So is my screen visible to everyone? Should we start? Swati ma'am? Okay, fine. So should we start? Yeah. Okay. Thank you once again, everyone, for joining us. And today, as we all know, that it's a even month August meet, so we have a breast meet this time. And these are presenters, our guest faculties, and the moderator. And today we have a very interesting topic. The topic which usually like we see in our day-to-day practice, and most of the time we are so much confused how to manage the patient, because not every time the situation is very straightforward. Not all the investigation they give us a direct indication that now this is the way you should treat the patient. So this case is also very atypical case and very interesting case. So she was a 35-year-old female, multiparous. Multiparous, the last delivery was conducted around 11 years back, and both the children were adequately breastfed. She presented to us with the left breast acute inflammatory lump, which for past 2 months, and she came from very far place, Lakhimpur Kheri, and she had a mica in Meerut. So after she already, by the time she came to us, she already received multiple antibiotics, and along with that, she had a progressive nipple retraction. With those antibiotics, her pain was partially relieved, but the swelling was not at all relieved, and it was slightly progressive only. The nipple and the swelling was there. When she came to me, she had a fever of 100 to 101 degree Fahrenheit for past 5 to 7 days. So friends, just please have a look of the patient. You can see the right breast absolutely normal, but there was a swelling occupying whole of her left breast, majority of the part, especially the central portion, with a nipple retraction. If we see the patient from the lateral view, now you can very well appreciate that there was a swelling occupying the outermost quadrant of the breast with overlying erythema, and the nipple was retracted, and the nipple was permanently retracted and not correctable. As a first line of investigation, we asked the patient to get an ultrasound breast done, and I request Dr. Vimukta to please describe the images to us. Okay, so now that we knew that this, yeah. So basically, the overall impression was, yeah, sorry. Yes, Dr. Vimukta. Yeah. So actually, basically, the overall impression was a chronic organized abscess. We knew that now she has an or because apparently it was looking a very lesion, but on ultrasound we were a bit relieved that she had some sort of infection that is organized. We aspirated some pus from the cavity, ultrasound guided, and we PCR. But both the reports were non-contributory to us. The culture was sterile and the TP-PCR was also negative. Fine. We also had blood investigations, and apart from the mild anemia, we just found that her TLC was mildly raised, polymorphs were raised, and NLR was 6.7, which was raised. So our clinical impression was that she must be having some non-lactational organized abscess, which may be a sequelae of mammary duct associated inflammatory disease. Most probably we are dealing with antibioma, and because her symptoms were suggested, there was a remote possibility of tubercular mastitis based on the duration of the symptom and the uh, organized characteristic of the lesion. By the time we were investigating her, we also asked her to, we also started her on broad spectrum antibiotics to see the response in another 3 to 4 days. And we found that there was no significant response in her case, and the swelling will definitely not subside with that. So we asked her for surgery. Our plan was to excise the organized collection with radical memory duct excision if required, and with the eversion of the left nipple so that her chances of recurrent infection will come down. So this is the peroperative image. And friends, you please appreciate this. There was a dead necrotic tissue coming out. It was a normal whitish areas. This you can appreciate. But most importantly, what I want to show you is this toothpaste like collection. This is very characteristic feature that we see in any patient with retroareolar duct involvement. Uh, these ducts are usually dilated and they are filled with this toothpaste like whitish or yellowish material, which come out like a cream. So it is very characteristic of it. So in her case also, we found such type of collection. In fact, all the ducts were involved. And this is the post-operative outcome that we achieved. So here also, friends, I would like you to please assess the skin and the stitches. So this skin looks absolutely fine, and the stitches are also dry. Except for some mild superficial necrosis of the nipple, we don't find any abnormality, except for because of tissue loss, there is some dimpling. So we sent the specimen for histopathological examination, and I request Dr. Chani to describe the images to us. Yeah. मेरे सामने तो next done, sir. Coming. Okay, so with this histopathology, our the preoperative diagnosis was also confirmed that she was having some acute on she was having some antibioma like features because there were a lot of acute inflammatory cells. And since now the report was also not suggesting us for any long term therapy, and the stitches were also healthy, the wound was healing, so we just asked her for a regular follow up, and we were very happy that at least one case is done. But to our disappointment, within 2 weeks this patient presented to us with a lesion like this. So we everything was very surprising because before that her lesion was absolutely healed, everything was okay, and the patient was also very apprehensive. What has happened? So in last this all lesions appeared in last around 5 to 7 days. So she came again to us with this lesion, and we were also very surprised. But like, those were looking. We have multiple differentials in our list. Importantly, like we thought maybe it could be some sort of chemical allergy or some fungal infection. So what we did, like we asked her, we started her on anti-allergics, antifungal, some broad spectrum antibiotics to see the response. The ultrasound was done. We showed only subcutaneous thickening, nothing else. So we just saw the response, but again to our disappointment, she didn't show any response. Now we again thought of those occasional granulomas which were reported in histopathology, and just considering those occasional granulomas and the fact that the patient has some recurrent problem, infection, wound related issues, we gave her a trial of anti-tubercular treatment. So we asked her to take this treatment for at least 1 month. We'll see the response to see whether it's worsening or static or resolving. And accordingly, we put the patient on a close follow-up. And to our surprise, we found that within 3 to 4 weeks, like her lesion started showing a dramatic response. So at around 4 to 6 weeks, her lesions were like this. And since now that we are getting the response with only anti-tubercular treatment, we continued the treatment and we completed the therapy. And this is the image. Within 3 to 4 months, her skin became absolutely normal. This patient completed her anti-tubercular therapy for 9 months, and now the 2 years have passed, and the patient is still asymptomatic. Now she doesn't have any problem. So why we have discussed this case in this forum? First of all, just want to revise a basic understanding of tubercular mastitis to understand the clinical, radiological, pathological, and microbiological features, to differentiate between the various other causes of chronic mastitis, to understand the utility of various diagnostic procedures in diagnosing such cases, to understand the treatment and follow-ups, and to find out the role of surgery in tubercular mastitis. So, friend, hello. Uh, yeah, Chani. Uh, uh, Actually, I think the slides are running late. They are showing some delay on the screen. Okay, fine, fine. So, should I move ahead? Okay. So, tubercular mastitis is a rare form of the extrapulmonary tuberculosis. It is caused by Mycobacterium tuberculosis. It was first reported by Sir Ashley Cooper in 1829, where he described this swelling as the scrofulous swelling of the bosom. It is very rare in the Western countries. That's why, like, a whole list of idiopathic granulomatous mastitis will come, but rarely do they publish on the tubercular mastitis. But in countries like India, Africa, the incidence range from around 3 to 6%. Lactating, the breast as such is a very resistant organ for tuberculosis. However, when the breasts are lactating or there are hormonal hyperstimulation features, then they become more prone. And it has been postulated that most probably because of increased blood supply or dilated ducts, they are more vulnerable for laceration and infection. They are usually unilateral, and males are rarely involved. And whenever any male is found to be involved with the tubercular mastitis, one should always consider some immunodeficiency syndrome like AIDS, diabetes, steroids, smoking, etc. So tubercular mastitis could be primary when there is no other focus identified, or secondary. Like we find some focus anywhere, and most commonly it is pulmonary. The routes of transmission could be variable, like most commonly it is hematogenous, then lymphatics. It could be direct inoculation or direct extension from the thoracic wall or axillary lymph nodes, inoculation through traumatized ducts or skin abrasion. So there are various, but like still, for most of the infection, it is not confirmed from where that infection might have arisen. Sometimes we get the clue that this infection is arising from maybe the pleural cavity or lung. Yes, ma'am. ओके मैम, आवाज तो यहाँ नहीं है, लेकिन मुझे लग रहा है नेटवर्क इशू है थोड़ा। मैं थोड़ा स्लो बोलती हूँ। हाँ, ओके। नेटवर्क, ओके मैम, आई विल गो स्लो। अभी आवाज आ रही है हमारी? या हम थोड़ा और स्लो चलेंगे क्योंकि यहाँ नेटवर्क इश्यूज हैं यहाँ पर। ओके, बेसिकली जो रूट ऑफ ट्रांसमिशन है, वेरियस थ्योरीज आर पोस्टुलेटेड, जैसे कि हिमेटोजिनस हो सकता है, लिम्फेटिक हो सकता है, डायरेक्ट एक्सटेंशन हो सकता है थोरेसिक वॉल या एक्सिलरी लिम्फ नोड्स में, या इनोकुलेशन हो सकता है थ्रू ट्रॉमेटाइज्ड डक्ट या स्किन अबरेशन में। कई बार हमें many times we find the exact cause, but many times we don't find the exact root कि कहाँ से ये infection आया है, most of the time. So as already said, जो breast tuberculosis है, it is a masquerader. It is a great masquerader. Why? Because it presents with multiple, it has multiple presentation, multiple forms. So what McQueen did once, he classified the different forms of breast tuberculosis into 5 forms. So what are those? Based on the radiological and clinical features. So ये जो 5 forms हैं, that is, these are nodulocaseous, diffuse, sclerosing, acute miliary and tubercular mastitis obliterans. So what are these? ये हम अभी देखेंगे one by one. So first and foremost is nodulocaseous. This is the most common form of presentation because ये एक slow growing, painless या minimally painful lesion की तरह present होता है. When it involves the skin, later on it may form some sinus or fistula. Otherwise, अगर वो जब skin involvement नहीं है, तो most of the time they present with some firm to hard mass. The second form is the diffuse or disseminated form. In this, the most of the part of the breast is involved. Predominantly, there is skin involvement, and it mimics inflammatory breast cancer. Later on, there are caseation, and those caseated lesions then burst out through the skin, form multiple foci of painless sinuses. Dr. Vimukta. Yeah, Dr. Vimukta. Now you are audible. Yeah. The third form is the sclerosing variety. In this sclerosing, in sclerosing variety, usually the lump is very hard and it is very speculated because of excessive fibrosis. So it mimics some serous carcinoma type of feature. Mostly these type of lumps are present. Yes, Dr. Bhumika. The another important form is the tubercular mastitis obliterans. So what is that? When it is the infection in this form, the ducts are infected, which causes the proliferation of the lining epithelium with marked epithelial and periductal fibrosis, just something like periductal mastitis. So these type of patients present with the lesions in the periareolar lesion, in the periareolar region, and mimic something like periductal mastitis. So the imaging features are. But not only that, there are patients who present with combination of all these forms. So there in this patient, like this patient has a nodulocaseous form as well as tubercular mastitis obliterans, something what our patient had. So another important is the acute miliary. It is extremely rare, and it is usually present as a part of generalized miliary tuberculosis. Patient has multiple generalized miliary lesion, and and in association with that, the lesions are present in the breast also. So they have absolutely different presentation. So McCune has classified the lesion into five forms. It is bit simplified by Tiwari and Shukla, and they describe three forms: nodulocaceous, disseminated tubercular mastitis, and tubercular breast abscess. So this tubercular breast abscess, this feature is not described by Macron, which is described by Tiwari and Shukla, and we know that this is also one of the important features. So anyhow, some of the clinicians are comfortable using McCune, and some of the clinicians are comfortable using Tiwari and Shukla, and both are perfectly fine. So, as already said, it's a great masquerade. How? Because it its its clinical history may vary from like acute to subacute to chronic. So majority are subacute, but common is also common. But acute sometimes we get. So if some patient presents with some acute symptoms, we just cannot rule it out. Though low in the list, but tuberculosis can be present in those lesions also. Now, breast lumps. Majority of the breast lumps in tubercular cases have some mild pain. Like they may say there is some occasional pricking sensation. Otherwise, most of the lumps, other than that, are painless. Sometimes we may get painful lesions, especially when they have some secondary bacterial infection. Tubercular toxemia-like symptoms, the characteristic features of the tuberculosis are present in less than 20% of cases, like fever, malaise, night sweats, weight loss. So these are not the very helpful. Though if it is these symptoms are present, we are more sure. But if it is these symptoms are not present, we just cannot rule out tuberculosis. But there are few characteristic features like painless or minimally painful lesions, long history, non-healing or recurrent sinus ulcer or fistula. These are some important characteristic features. If they are present in any case with breast problem, one should always consider tuberculosis somewhere in the list. So, the imaging is one of the major pillar without which we cannot work. And I request Dr. Vimukta to describe how this imaging helps us in making a diagnosis or managing a patient with suspected tubercular mastitis. Yes. 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 Thank you very much, Dr. Vimukta. And now, just like radiology, microbiology is the crux of managing tubercular mastitis. Without the help of microbiologists and without the help of the microbiological diagnostic test, we cannot move ahead. Okay, thank you, Dr. Ruchi. It was a wonderful presentation, and I request Dr. Chani, pathology, the last but the very important aspect of managing any patient with tubercular mastitis is the pathology, because like without pathology, most of the cases we are good for nothing. We cannot manage the patient without that. And how the pathology helps us in managing the patient with suspected tubercular mastitis, I request Dr. Chani to help us in that. Yes, 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 Yes. Okay, so thank you very much, Chani. But the problem what we face is not all the in all cases our gold standard tests are positive. So majority of the cases we have to work in the absence of gold standard. So the main question regarding the diagnosis of tubercular mastitis comes: to whom should we give more emphasis, the detection of microorganisms or to the surrogate markers or some study like this, which showed that the direct detection technique, especially in possibacillary lesion, there may be some delay in diagnosis and treatment. Cultures, they have high specificity, low sensitivity, and the polymerase chain reaction PCR has 25% sensitivity, as already discussed. Therefore, generally pathological examination appears to be more of practical use than bacteriology, especially considering that both culture and PCR are technically challenging and cannot be applied in many settings. So, in most of the cases, the diagnoses are made based on pathology and confirmed ex juventibus as they responded to anti-tubercular therapy. First, we'll discuss about the treatment and then some salient points. So, once a tuberculosis is diagnosed, the ultimate treatment is the anti-tubercular treatment. The patients are categorized as category 1, and usually 6 months of treatment is initiated. But there are studies where they show 9 months of treatment is more effective in terms of less recurrence rate and early relapse. So there are 2 months of intensive phase with 4 drug therapy and 4 to 7 months of continuation phase with 2 drug therapy. Important point I would like to emphasize is, if we add fluoroquinolones, it has been found that it helps managing the patient by dealing with the secondary bacterial infection, especially in the post-operative cases, and also is found to have improved the recovery rate. So moxifloxacin is one of the medicine which is found to be very useful in such settings. So what is the role of surgery in tubercular mastitis? Usually, it is avoided if tubercular mastitis is diagnosed in the initial investigation. Usually, the surgery is avoided. Generally, complete resolution is possible with anti-tubercular treatment. In only 10 to 15% cases, some minor surgical procedure is required, and only in less than 5% of cases, some major surgical procedure like quadrantectomy or anything more than that is required. So, usually, surgery is indicated when there is solid lesion. We want to take some biopsy, either core biopsy, incision, or excision, when the diagnosis is not confirmed. Or we do the surgery whenever there is some residual lesion following completion of anti-tubercular therapy. In abscess, majority of abscesses, they resolve very well with anti-tubercular treatment. What we require many times is the anti-gravity repeated aspiration. Incision and drainage is required if they are secondarily infected with significant pain and they're not responding to medical management. Fistulas and sinuses, usually the surgery is required if there is a residual lesion, symptomatic lesion, following the completion of anti-tubercular treatment. So if now we summarize, if tubercular mastitis is diagnosed in the preoperative period, we first start the anti-tubercular treatment, and we do the surgery only if there is any operable residual lesion which is symptomatic, or there is some sinuses or ulcer. If tubercular mastitis is diagnosed in the post-operative period, when we miss the diagnosis in the initial workup, then after the diagnosis, we start the anti-tubercular treatment. And and it is very important, though many clinicians may feel that the patient is apparently normal and the tissue is removed, the infected tissue is removed, then what is the use of giving anti-tubercular treatment? But it has been found that if we don't start the anti-tubercular treatment and complete the course, the patient may experience wound-related complications. The wound usually don't heal if we don't start the anti-tubercular treatment. So it is must. So now if we apply all this knowledge in this present case, so this patient presented to us with a combination of nodulocaseous with tubercular mastitis obliterans. In this patient, unfortunately, the initial microbiological workup did not help us to find out to diagnose tuberculosis. In fact, in histopathology also the things were not very clear. But this case we diagnosed as tuberculosis based on the treatment response that she had. So some take-home messages which I would like to give with this presentation, that tubercular mastitis, it is very less in developed countries, though like their incidence is also rising because of the rising incidence of AIDS and HIV, but it is still very common in India. It may present either as a primary presentation or secondary. Reproductive age group females are very commonly affected, males are very rarely affected, and if at all they are infected, then we should consider some immunocompromised state. It is a great masquerader. It can present in any form, so we cannot rely on just one investigation or one presentation. We have to keep our eyes and ears and everything open to see that we are not missing it. Ultrasound of the breast is the imaging of choice, as Dr. Vimukta told. Uh, Gold standard is the isolation of Mycobacterium tuberculosis, which if it is there, we are certain that we are dealing with it. But if it is the incidence of isolating is that Mycobacterial tuberculosis is very less. Like out of 10 patients, we in only 4 patients we do get this result positive. Montauk's test has a poor diagnostic value, but still it holds a position because of its cost, its availability, and anti-tubercular treatment. 6 to 9 month therapy is recommended. Sometimes, based on the symptom response, 12 to 18 months of therapy is also instituted, but it depends on the individual choice. Surgery in post anti-tubercular treatment for only we do for residual lesion. It is not the first treatment of choice. First treatment of choice is the medicine anti-tubercular treatment. We do surgery only for residual lesions or when we miss the initial diagnosis of tubercular mastitis. And friends, please mind, in a country like India, the diagnosis of idiopathic granulomatous mastitis must be made with caution. Even in the absence of AFE, the response after a sufficient trial of anti-tubercular treatment must be considered as a part of one of the major guiding factors in deciding the definitive therapy, because most of the times we don't ask for those elaborate investigation. We just try to rule out tuberculosis, and we know that it is not easy because like even if the patient has tuberculosis, the reports may not guide us. So most of the time they are the missed diagnosis. And in idiopathic if we in tubercular mastitis, considering mistaking it for idiopathic granulomatous mastitis, if we treat the patient with steroids, maybe intralesional or systemic steroid, there are high chances that we may be flaring up the disease and causing more harm to the patient than the of doubt. In a country like India, always give a trial of anti-tubercular treatment for at least 1 month to see the response, and then decide upon your treatment for later on. But more research are warranted. And with this, I would like to thank you all for your patient hearing and your precious time that you have given to us. Now I request Dr. Swati ma'am to please take over. Uh, yeah, yes, please, please. You know, Dr. Parul may be the right person to answer. Yeah, about gene expert and other things. AFP staining. Dr. Parul is with us. Dr. Dr. Parul has also joined, ma'am. Swati ma'am, Dr. Parul has also joined it. Yeah, basically, Dr. Anjali uh, uh, Davle, if I can further add on to this, I totally agree with ma'am. In country like India, what the take-home message, that's what I try to give, is even granulomatous mastitis, idiopathic granulomatous mastitis is very much projected. Whenever you type about granulomatous mastitis, it will not tell you more about tuberculosis. It will tell much more about the idiopathic one, but it's not the case in our scenario. It is always safe. Maybe it could be idiopathic granulomatous mastitis. If you are completely sure that it is idiopathic only, then go directly for steroid and methotrexate. But if there is slightest of the doubt, it is always good that you start her on anti-tubercular treatment. Just for 1 month will hardly matter, but it will show up the response. And if there is some response, it is always good to continue till you are getting the response. But if you don't feel, if you feel you are not having the response, then certainly you can again go for methotrexate and steroid. Regarding the experience that you asked, not much of the experience, but recently in some of the patient with idiopathic granulomatous mastitis suspected, I injected I gave the intralesional steroids, and it was really, they had dramatic improvement. The lump almost disappeared clinically, but radiologically, the radiological features did not change much. But certainly, clinically, they had a very good response with that. So, but more studies are required, at least from my side. More experience is required. Maybe in some other forum, I will try to put this entity as a separate entity to discuss upon, so that we will discuss more about its diagnosis as well as the treatment protocols, which is very rarely discussed. Actually, I think this Wegener's and yeah, just one thing, ma'am. I want to ask some experience from the institutes like SGPGI and others. Ma'am, how frequently, like for idiopathic granulomatous mastitis, usually we just ask for AV. Most of the time, we just rule out tuberculosis. This and is how important is it to really rule out these other causes as well, then before labeling the patient for idiopathic? Usually we just rule out the infective causes like acute bacterial or tubercular, and some like, you know. So, ma'am, suppose a patient with idiopathic granulomatous mastitis, what strategy do you follow in managing such cases? Occupying a very large area, not surgically operable, not amenable for surgery. Anjali ma'am. अंजलि मैम, आर यू एबल टू हियर मी? अच्छा, ये एक और मुझे क्वेश्चन पूछना था। मतलब मैनी टाइम्स जब मैंने कुछ पस एस्पिरेट किया, तो वो बड़ा ग्रीनिश कलर का पस था, और वो फुल, यूजुअली इम्पाइमा नेसेसिटेंस टाइप का था। दैट वाज एन एब्सिस कैविटी ओनली, एंड दैट केम, उसमें फ्रैंक ट्यूबरकुलोसिस एएफपी स्टेनिंग पॉजिटिव मिली मुझे उस तरह के लीजन में। तो क्या ये करेक्ट? हाँ, वो थोड़ा बड़ा ही ग्रीनिश था और एकदम ही फ्रैंक पस था। तो क्या ऐसा कुछ होता है? बिकॉज यू सी लॉट मैनी सच, आप तो आपके पास तो हर तरीके का सैंपल आता है। बिकॉज मैं इस तरह का पस मिलता है, मेरे दिमाग में एक बार आता है कि आई एम डीलिंग विद ब्रेस्ट ट्यूबरक्लोसिस। मतलब स्लाइट ग्रीनिश टिंज था, हल्का सा स्मेल होता है उसमें, और एकदम से ऐसा लगता है कि यार ये तो शायद मैं टीबी डील कर रही हूँ। मतलब उसको एकदम कोल्ड एब्सिस की तरह, उसको कोई प्रॉब्लम नहीं है, कोई एक्यूट इन्फ्लेमेटरी फीचर्स नहीं है, बस एक लंप है। अल्ट्रासाउंड कराया, एक एब्सिस कैविटी मिली, जैसे ही मैंने एस्पिरेट किया एक भर के पास आया, तो एकदम से दिमाग, और लेकिन वो ज्यादातर टाइम ग्रीनिश होता है, हल्का सा ग्रीनिश। वो सुडोमोनास, यू डोंट हैव दैट। हाँ, वो सुडोमोनास तो या हाँ, सुडोमोनास तो फर्स्ट पॉसिबिलिटी लगती है कि चलो ग्रीनिश है शायद वो। ओके, फाइन फाइन, सो इट मे बी माय पर्सनल, ओके, सम नेटवर्क इशू। वन वेरी इंपॉर्टेंट पॉइंट आई लर्न फ्रॉम दिस, या प्लीज। Yeah, I was thinking the same ki wo just, okay, fine. One very important point I have learned from this discussion, as what Dr. Parul said, कि clinically diagnosed tuberculosis भी होता है कुछ। Otherwise, I was thinking कि यार मतलब, am I really doing right कि I am giving some empirical therapy for 1 month, for 1 month at least to see the response, because with very like fear, I usually start the treatment, because like many clinicians, they are very so that we usually do, but like some, what is this CB net? Can you please elaborate, and what is the cost and other things for our listeners? CB net is what? TPPCR. Perfect. Thank you very much, because these things, these different tests almost. Okay, wow, that's very nice information. I didn't know about it. Yeah. Yeah, that was wonderful information. Matlab, too many information came out of this presentation, not from the presentation, but from the discussion that we had. And mm, any other questions anyone want to ask? Our experts are still here with us. And if not, I may request Swati ma'am to please take over, and we may wind off our session with the promise that we will meet again next month, and I will tell you what the other interesting topics are in the line. Ma'am, your voice is not audible. Yeah. Thank you very much. Uh, thank you very much, ma'am, Swati ma'am, for giving your precious time. Thank you, Dr. Parul, Anjali ma'am, and all my speaker friends. Before we leave the meeting, just a small information. Next month is our and is the odd month, and we have our endocrine meeting. And in that meeting, I request everyone to join, because in that meeting we will be telling you the about the dose titration, the thyroxine supplementation in different clinical conditions. So we will be telling you more about the practical aspect of thyroxine supplementation, management of hypothyroidism in various clinical, and that will be a very wonderful session that I'm very sure. So please keep connected with us. Keep connected with the BRENDOS WhatsApp group. And those who don't know about us, please ask them to join us, share the link, the group link, so that they can also join us in subsequent meetings. Okay, so next month, please join us again, because that will be a common topic. Majority, I think, more than diabetes is the hypothyroidism that the people are suffering with. And this dose management will be something which will be helpful as an individual and as a doctor for the patients also. So please do join us. I will be sharing the link subsequently. And this meeting is recorded. We are on Facebook live now, and soon as possible. And from next time onward, we will be live on YouTube as well. So with this, I would like to thank you all, and I request we may now disconnect the meeting. We can now leave the meeting with the promise that we will meet again next time. Okay, thank you, ma'am. Thank you. Okay, thank you, Chani. Thank you, Charu. Thank you, Ruchi. Thank you, Parul, Dr. Parul. Uh, thank you, Dr. Hema, Dr. Sela, Shweta ma'am. Thank you very much to everyone. It was a wonderful time together, and we will meet again with some new topic, with some new clinical problems, certainly. Yeah, I loved working with you all. Thank you very much. And I learned too many things, too many things.